Okay? Okay, flip the packet. On this page is probably one of the most important pages in the whole packet. As such, we're going to go through a lot of stuff on this page. Nitroglycerin, of course, is important for every student to know for any exam. Notice the other names, isosorbide, Imdur. This is a vasodilator, you knew that already. But it also causes, since it's a vasodilator, it could cause you to fall or faint if you don't rise slowly, agreed? So you got to teach the same thing you taught with the hypertensive meds. Does it work on preload or afterload? Afterload, and it's kind of like a little bit on preload, but afterload was the right answer. Okay, now it increases preload, it decreases afterload. It allows for quality movement of fluid. Now, you cared about the vasodilator. Now, chronic stable angina. Remember, we talked about this. Chronic stable angina. Patients on nitro, they have two different types. One is you could take it sublingual. This is to treat an angina attack right now. Or you could take it as a PO or as a patch. That would be called a maintenance drug. Ain't that right? If it's a maintenance drug, can I use it for chest pain occurring right now? Hell no. So when you teach patients, you got to remember to say sublingual nitro is used to treat actual chest pain. You take one now, you wait how long? 5 minutes. If you still have pain, what do you do now? Take another one. 5 minutes later, you still have pain. Now what? 911, and then take another one. Don't forget, this is probably a heart attack. So 911, take another one, and take an aspirin. Get me started on my Mona early. Okay, so every 5 minutes times 3 doses is essentially what you should be writing down. All right? Now, the nitro patch free period is so that the patient does not become tolerant. We give them overnight, no patch. So look what it says. It says nitro patch free period, about 10 to 12 hours, is to prevent tolerance. What's the most common side effect? Headache. So highlight headache. That's the most common side effect. If your patient has a history of a heart attack, then taking nitro every 5 minutes times 3 is going to kill them. In other words, they're wasting their time. If they've had a previous heart attack, they need to come see us yesterday. You can take the little funky nitro, but not times 3. Just take one and get in here. Okay, don't forget, it's a totally different teaching for a patient who's actually had a heart attack before. Well, hell, you're probably having another one. So in that situation, you just take one and get in here as soon as humanly possible. Okay, so just take one. All right, now, if we keep reading, we see our thrombolytics or fibrinolytics. These are your clot busters, as you already know. If you look at the word lytic, it means destruction. Destruction, if you look at the root word, thrombo, destruction of a clot. Fibrino, destruction of fibrinogen. If you have these clot busters, you have to be very careful with the next instructions. Listen to me very carefully. You have to use the clot buster within 3 hours of a stroke, within 6 hours of an MI or PE. Does that help? They're not the same time frame. I wrote them for you, but you have to know the difference. The brain is more important than the heart. So you ain't got but 3 hours with the brain, which is stroke. And you have, the 6 hours with the heart attack. Now, what are they? Well, they're enzymes. They eat away at the clot. So number 2, all of them end in ASE. Do y'all see that? Okay, so all of that ends in ASE. They are enzymes. Now, pay attention to number 3 because it's not with everybody. It says chase with heparin only after 24 hours. Who don't we chase it with heparin on? Stroke. We don't trace it. We would have never used it, much less chase it. If you had a hemorrhage, we're not using TPA, are we? Think about those answers. So what did we do? We said don't chase it with heparin if you have a stroke. You can chase it with heparin if you have a PE. You can chase it with heparin if you have an MI. But you cannot chase it with heparin if you have a stroke. The only thing we chase with heparin, the only thing we chase TPA with after a stroke, and this is always important for you to know, is aspirin. Let me say that again. The only thing we chase TPA with after a stroke is aspirin. We're not going to use no heparin after no TPA. No way in hell are we going to use Coumadin. We're only going to use aspirin, 325 milligrams. Now, then you see it says dissolves the clot. What should you be doing with this drug? Watching for oozing at the IV site. Number 1 sign of bleeding. Gonna be bleeding and ain't gonna stop. Oozing at the IV. Now, right below number 4, you have a little tiny bit of space. Or you can use it right between number 8 and the miscellaneous word. Or you can write it down under vasopressin. I don't really care where you write it. But these meds that I'm about to talk about now are the most important on the page. I'm going to add some, and we're going to cover the ones that are already here. The 5 meds that I'm going to add include, and I don't really care where you write them, I'm going to add morphine, mannitol, Romazicon, Levofed, and Natriotide. And this page is not just your dysrhythmic or miscellaneous ICU drugs, but this page is also standing in as just emergency room drugs, period. Emergency room drugs, period. Okay? So let's look at the ones that are already there, because they're easy. Amiodarone is part of our mnemonic. We teach you in this class, and we'll go over it again thoroughly on Monday, but we teach you A, B, C, D, and C, V with T, E, E for AFib and A-flutter. So let's look at the A. A stands for amiodarone, and A stands for anticoagulant. So A, B, C, D, and C, V with T, E, E. A, B, C, D, and C, V with T, E, E. Now, don't go crazy with that, because again, we teach it on Monday. But for now, what you should know about this whole thing is that the A stands for amiodarone, because the number one indication is any dysrhythmia. A for amiodarone, A for arrhythmias or any dysrhythmias, whether it's AFib, A-flutter, V-tach. If I were you, I'd highlight V-tach. V-fib, doesn't matter. A for amiodarone, A for any dysrhythmia. A-fib, A-flutter, V-fib, V-tach, highlight V-tach. Now you got to watch two things. You got to watch PFTs. What is that? Pulmonary function test. And you have to watch TSH. Thyroid. I highlighted, I wrote it in for you. You just need to highlight it. Almost everything is written. The next drug to highlight is adenosine. Adenosine is going to treat really ridiculous SVTs. SVTs, by definition, is a heart rate greater than 150. Heart rate greater than 150. For the record, SVTs stand for what? Supraventricular tachycardia. Yep, that's pretty serious stuff. I had a patient who was pregnant and her heart rate was 225. So I sent her and her bundle of joy to the ER with the 911 call, and as soon as she got there, they gave her adenosine. Now, adenosine actually is kind of weird, because A for adenosine, A for it puts your heart in asystole. It works by stopping your heart first. It's a bolus drug that we give in the ER. Next drug you should highlight is atropine. Notice it's an anticholinergic. And I teach you that all anticholinergics dry up everything. The main indication which you will highlight is bradycardia. But it also does a really good job at treating asystole. So don't get confused. Adenosine causes asystole. Atropine treats asystole. There has not ever been a time when I didn't run a code or be involved in a code and I didn't give atropine. There's never been a time in 30 years of practice. I always give atropine. Every code you run. So it's going to take a heart where there's none and all of a sudden give you one. So it treats asystole. Okay? It does dry up secretions, and you had to remember, just so you could throw up, it also inhibits the vagus nerve. So it dries secretions, which is there for you already, and it inhibits the vagus nerve. It's the vagus nerve that gives us a bradycardia. So if it inhibits it, well, you'll be fine. Lidocaine, I would highlight it. This is the drug of choice for V-tach, which I would write. V-tach. Lidocaine is a drug of choice for V-tach and PVCs. Procainamide. Procainamide is going to be used for practically anything lidocaine could be used for. What I want you to write is Wolff-Parkinson-White syndrome. So lidocaine can be used to treat the Wolff-Parkinson-White syndrome that we see with patients that have AFib. And I really got to say that again. Procainamide treats the Wolff-Parkinson-White syndrome that we see with AFib. Some patients can go into Wolff-Parkinson-White just from being AFib. You have to write it in, Wolff-Parkinson-White. Okay? Okie dokie. The next one I want you to highlight. I want you to write in mannitol. You know this drug already. This is a review only. But you know it already, but I thought it should go on this page as an emergency drug, IC drug. Mannitol, as you know, you have to use a filter for crystals, right? And it's for ICP, but you have to use a filter. Okay. Natriotide, which is octreotide. Natriotide, which is octreotide, another name for octreotide. So you're writing it in. Natriotide is on the board, which is another word for octreotide, and is also another word for somatostatin. This, as you know from your endocrine, is used to treat acromegaly. The emergency room use of this drug is for a GI bleed. The emergency room use of this drug is for a GI bleed. If you'll look there, I gave you dobutamine earlier today. It strengthens the contraction, right? Dopamine is a potent vasoconstrictor, which I did write, but I remind you to write another note there. The other note I want you to write is that it dilates the renal arteries, leading to increased urine. So with a patient on dopamine, it's a potent vasoconstrictor. It treats very low blood pressure, and it dilates the renal arteries, which increases the urinary output. So that's why we have down there renal failure. It may work really well with the renal failure patient. Okay. Next on the lineup is Digoxin. This is a cardiac glycoside. It not only strengthens the contraction, it actually slows, quote me here, it slows the conduction through the AV node. Slows the conduction through the AV node. So if you look at the D in A, B, C, D, and CV with TEE, the D would be an option for the patient in AFib or A-flutter because it's digoxin. So you don't have to really go crazy with it now because I'm going to teach it Monday, but A for amiodarone, B for beta blocker, C for calcium channel blocker, D for digoxin. Any of those work, but the goal is to slow the heart rate. So digoxin will slow the heart rate, and it's very useful in the treatment of AFib or A-flutter, CHF patients as well. Remember, dig is toxic at 2. Okay. Then you see when it is that you hold it, if the apical is less than 60. But if it's a child, then you'd have to wait till, you'd have to go as high as 100. Hold the drug if its heart rate is lower than 100. Okay, now, naloxone. When it comes to naloxone, remember that it is going to need to stay wrapped. Naloxone is the antidote for your opiates like heroin, fentanyl, Oxycontin, any opiate. Usually you have to repeat it. Someone I know that was working on the addiction unit, more like an outpatient, but not quite, but it wasn't severe inpatient. Patient died from a fentanyl overdose, and he had to pack it in between the credit cards in his wallet while in the hospital. And the patient got 3 doses of Narcan, and it still didn't work. And the guidelines was saying for this floor of nurses, just keep using it. Don't stop. Because fentanyl is 400,000 times stronger than heroin. So just keep giving it to them. Just boom, back to back. So you can repeat this. Okay? You can repeat this. It should be working in 2-3 minutes. If it's not, just keep repeating it. You probably know yourself it's a nasal spray or an injection. Okay, you know they sell this over the counter. Now they do, because all the crazy shit going on with heroin. Okay, the complication is pulmonary edema. Narcan makes all vital signs go up, including pain. So if you reversed all the, opiates and your patient was post-op, they're going to be in pain. So pain can come back in a patient that was already experiencing some. Norepinephrine is the same thing as Levophed. Norepinephrine is the same thing as Levophed. Now, we'll talk about Levophed in a few minutes, but right now you just need to know those two are used interchangeably. Vasopressin is a very, very, very potent vasoconstrictor, and the reason why you care for vasopressin is that I want you to put in your notes, it increases the blood pressure, but it will decrease the urinary output, which is why we use it for DI. So vasopressin, it lowers the urinary output, so it's a perfect drug for DI. The other name for this drug that you probably know already is called DDAVP. Our emergency room use of this drug is basically for the patient that has a GI bleed, such as esophageal varices, and if you think about what it's saying vasopressor. Well, what is it doing? It's pressing the blood vessel. Well, what is that? Vasoconstricting. So that makes sense. Okay? Now, I had you write down Romazicon. Do y'all see that? Romazicon? Now, the other name for that, your test is still giving you brand names, when the reality of the matter is the NCLEX is all generic. But the generic name is flumazenil. The generic name is flumazenil. And when we talk about this drug, it is the antidote for an overdose of benzodiazepines. So it's an overdose. It's for an overdose of benzodiazepine. Specifically, the benzodiazepine of Valium, Ativan, Xanax. Okay, those are all benzodiazepines, and typically when we use a benzodiazepine, we're using it to calm the patient's anxiety for a different procedure. So if I'm going to give a patient a colonoscopy, I'm definitely going to give them a benzodiazepine. If I'm going to do a cardioversion on a patient, I'm going to give a patient a benzodiazepine. Doesn't that make sense? Okay, so it's to decrease their anxiety. Okay, we said morphine, yeah. Morphine, I told you to add that drug. As you know, morphine is an opiate that we use with heart attack patients. And the heart attack patients are very stressed. They're releasing catecholamines. When we give morphine, it will decrease the pain, and the pain will decrease. The decreasing the pain will lead to less anxiety. So again, morphine decreases the pain, and that decreasing of the pain leads to less anxiety. Less anxiety leads to decreased catecholamines. Catecholamines caused vasoconstriction, didn't they? So then let's go about it through the back door. Essentially, morphine vasodilates. So don't worry, I'm going to say that again because you got to get it. Morphine is an opiate. It decreases pain. As it decreases pain, it decreases anxiety. As it decreases anxiety, it decreases catecholamines. As it decreases catecholamines, it actually vasodilates because catecholamines vasoconstricted. It's like a roundabout way to get there. Okay. So it decreases the workload of the heart. Now, I saved the best for last. I probably would, if I were you, because there's so much already written on this page. I would turn the page for this one because it's a lot of information. And at the top of the sheet where it says anticoagulant, I want you to put Levophed. Now, we do have a rule. Levophed leaves them dead. I know, right? That's terrible, but it's true. So, don't forget that Levophed is a norepinephrine. That's what it is. It's norepinephrine. As such, it's a potent vasoconstrictor. The reason why we say Levophed leaves them dead is because it causes tissue hypoxia. So yeah, they may need Levophed to get their blood pressure up in shock. But while you're getting their blood pressure up in shock, you're causing peripheral vasoconstriction. That tissue is going to die if you're not careful. So we say Levophed leaves them dead. So we treat shock. We treat extreme hypotensive crisis. Patients that have an MI with no blood pressure. Septic shock. We treat all of that with Levophed. It causes extravasation, very damaging to the vessel. That's why you need to have a central line for this usually. It can cause a bradycardia. A bradycardia. Never use any MAOIs with it. Cannot use any MAOIs with it. And because it does have the potential to kill somebody, the antidote is this. The antidote is your phentolamine. Antidote for Levophed, which leaves them dead. Levophed leaves them dead.